My name is Joel Garcia. I was invited to the International Academy of Cardiology for a presentation on a validation of 3D modeling and CT reconstructions. As an interventional cardiologist, we have had the obvious limitations of standard angiography when it comes to imaging inaccuracies of the coronary tree. That includes foreshortening the fact that we use luminology, and sometimes we're not able to actually define the best available gantry to make our interventional procedures. For the most part, we get this information nowadays from trying to maximize the standard coronary angiography effort itself. We have tried to do rotational angiography. We have tried to do dual motion rotational angiography. While we do get a better impression of the coronary tree, we still cannot survive the imaging inaccuracies of foreshortening and overlap that we have from standard angiography. Of course, we're still exposing the patient to contrast and radiation, both of which presentations for the safety and efficacy of dual motion rotational coronary angiography and rotational angiography itself I presented here in prior years. As an effort to actually try to minimize those imaging inaccuracies, we've been able to get that information of the dual motion rotational angiography, the single shots, and the rotational angiography into a 3D modeling environment. That 3D modeling environment has allowed us to actually look at foreshortening overlap in the interventional suite, trying to minimize those and trying to make a decision as to what the best position or gantry is for the interventional segment itself. Well, that 3D model has been very well validated. We actually have a lot of data on it. But we are now using CT reconstructions and CT modeling and CT 3D reconstructions to actually make those decisions in the interventional suite. So we thought to validate the comparison of the 3D model and the CT itself. Well, for that, you actually take the 3D model into the interventional environment and take the CT reconstructed model into the interventional environment itself. You go through a center line process where you actually have to assign the center lines in the vessel hierarchy. As you try to then get an idea as to length, QCA diameter, and in addition to that, the best gantry position, you want to compare both 3D model and CT 3D reconstructed models. As it turns out, there's no difference in QCA diameter. There's no difference in length when you compare 3D models and CT reconstructed models in the interventional environment itself. The gantry position tends to be superior on CT than what it does on 3D models. However, that's due to the inherent limitation of the 3D model itself, where it has to be motion compensated, respiratory compensated, and also this inherent bias to the 3D model itself. As it turns out, CT can be safely used, and 3D models can be safely used into the interventional environment to guide decision-making onto interventions. It seems that CT and 3D are comparable for length and diameter, but not so much for the gantry positions. However, once you compensate those 3D models and you respiratory compensate them and movement compensate them, it seems that they're equal to the CT 3D reconstructed model itself. In conclusion, we are able to use both the 3D model data or the CT data into the interventional environment to guide decision making.